Hi, everybody. I'm Dr. Caplan. This is a talk I just gave to the Hawaii State Department of Health, the Office of Medical Cannabis Control and Regulation. It's an overview talk, and I hope you enjoy it. Disclosures, I am me, a board-certified family doc. I've founded a few companies, and I have a full-time clinic, for those of you who don't know me. And this is a boilerplate disclaimer. This is intended for educational purposes and should not be construed as medical or legal advice. Here's the overview. Basically here I'm going to talk through 6 key areas of cannabis care, each of which offers a closer look to how this medicine works, where the common misunderstandings are, and how we can apply it more safely and effectively. This talk dives a little deeper than most of the 101 talks I've seen around, but covering the realities of cannabis use in everyday people in everyday ways. In each section of this talk, I'm going to walk through a predictable pattern. We'll start with a myth, move into the science or the reality behind that myth, and then explore how that applies in practice, and then end with a takeaway that's hopefully simple and easy enough to hold on to. The goal here isn't just to share information, it's to make it practical, a little bit more human, maybe a little more trustworthy than what you typically get from a Google search at 2 a.m. Don't worry, if something goes by too quickly, I'll share ways to revisit the content at the end. All right, navigating cannabis and safe choices. So slide here, number 1 is the myth, isn't this just about getting high? This is the myth that really just won't die, like the idea that gum stays in your stomach for 7 years or that cold weather gives you a cold. The "it's just about getting high" narrative has framed public understanding of cannabis for at least 80 years. And to be fair, it's not entirely wrong. Yes, euphoria is one possible effect, and people who consume weed tend to be happier, but let's not confuse one effect with the whole story. If I said insulin was just about getting sugar under control, or that SSRIs are just about mood, would that fly in any clinical conversation? Of course not. The truth is that cannabis isn't just about intoxication, it's about modulation. And the endocannabinoid system that we're all born with touches nearly every major physiologic domain. Pain, sleep, appetite, immune response, memory, stress, and those are threads that run through the whole body. 93% of patients in one national survey reported therapeutic effect from cannabis. So no, this isn't just about getting high. That's like saying a scalpel is just for stabbing. So the insight here, we've been using this plant longer than we had countries. Cannabis has been in the medical record for at least 5,000 years. Let's put that into perspective. We've used this plant as medicine since before we discovered germs, before anesthesia, before we had written constitutions. The Chinese pharmacopoeia around 2700 BCE cites cannabis for gout, rheumatism, and constipation. Ancient Indian texts refer to it as one of the 5 sacred plants. In Egypt, cannabis was found in the mummified remains of Pharaoh Ramses II. In 1851, it was listed in the U.S. Pharmacopoeia. It wasn't until 1937 that we had criminalized it here in America. And that decision had less to do with the pharmacology and more to do with racism, fear, and a struggling paper economy. So when someone calls cannabis new or experimental, I remind them aspirin has only been around for 100 years. Cannabis, we're talking about grandparent medicine there. Food for thought, cannabis has been in medical texts longer than most countries have had plumbing. The world outlawed it before we knew the system it works on even existed. That's like banning a USB stick before we had computers in the 1800s. Schedule 1, the application. The laws changed, but really the plant didn't. In 1970, cannabis was placed in Schedule 1 under the Controlled Substances Act alongside heroin. Schedule 1 means no accepted medical use, high potential for abuse, and lack of safety under supervision. That's an interesting definition considering we now have FDA-approved cannabis-derived medications. Epidiolex is a CBD isolate approved for pediatric seizures. Marinol and Syndrose are synthetic THC analogs used for nausea and wasting in cancer and AIDS. In 2022, over 4 million patients in the US were registered in state medical cannabis programs, and nearly 90% of them used it to treat some form of chronic pain. These are not recreational outliers. They're your neighbors, parents, veterans, and patients. The science advanced, the public caught up, but the laws, they're still pretending it's 1971. So the takeaway here is cannabis is medicine as it always really has been. Cannabis isn't one thing, and neither are you. Let's go ahead and debunk this early. Not all cannabis is the same. But you wouldn't know that from the questions people ask. What strain should I get? Is this one stronger? What's the highest THC you've got? Imagine someone walking into a pharmacy and asking the pharmacist, what's your strongest pill? Cannabis is more than THC, more than sativa and indica, more than whether the guy at the counter thinks it's fire. Depending on what studies you read, there are over 140 cannabinoids identified so far. And if you consider flavonoids, terpenes, and the other aromatic oils in the plant, these that influence how a product feels, the therapeutic potential is just amazing for this whole plant. For example, limonene can uplift, myrcene can be sedating, caryophyllene can reduce inflammation. Many impact the way tumors can grow or travel, and some work well to block damaging UV light, like sunscreens. When you reduce cannabis to what's the most potent, you're not shopping smart, you're playing roulette in a lab coat. Saying weed is just weed is like saying all pasta is spaghetti. Technically true, functionally ridiculous. If you think all cannabis does the same thing, I'd like to introduce you to tequila and cough syrup. Both liquid, very different weekends. Cannabis contains hundreds of compounds, each with a job. Cannabis is a polypharmaceutical plant. That means it's not just one compound doing one job, it's a formula, a symphony of biologically active chemicals. THC binds to CB1 receptors in the brain to produce euphoria, pain relief, appetite stimulation, and other impacts. CBD doesn't bind as directly, but modulates CB1 and other receptors, reducing anxiety and inflammation without the high we come to know of from THC. Then we have CBN, CBG, CBC, THCV, and dozens more. Some stimulate appetite, some reduce it. Some calm the nervous system, others activate it. And alongside the famous cannabinoids, you've got terpenes, the unsung heroes. Terpenes don't just affect smell or taste, they influence absorption, duration, and synergy. This is what the cool kids call the entourage effect. The entourage effect refers to synergistic interactions between cannabinoids and terpenes. So when someone asks what strain works for sleep, the answer isn't in the name, it's in the chemistry. Choosing cannabis is more like compounding than consuming. In clinical care, we don't throw pills at patients and hope they stick. Okay, at least the good doctors don't. We adjust doses, change ratios, time medications around circadian rhythms. That's exactly how effective cannabis works too. You want pain relief without a couch lock? Maybe a 2-to-1 CBD to THC in a tincture format. Want help staying asleep but need to stay functional the next day? A myrcene dominant capsule with a delayed onset. This isn't about the strongest flower. It's about tailoring cannabinoid ratios, terpene profiles, and delivery methods to the job at hand. Cannabis is a toolkit. The question is, thinking about the consumer, not the medicine, what are you trying to build? Cannabis isn't one thing, and neither are you. There is no one-size-fits-all cannabis product, because there is no one-size-fits-all human body. Your endocannabinoid system varies based on age, hormones, stress levels, even the time of day. The cannabis products that work for someone with multiple sclerosis might feel overwhelming for someone with mild anxiety. It's not about finding the best product. It's about finding the right match for your receptors, your condition, your timing, and your goals. Cannabis isn't one thing, and neither are you. The format shapes the experience. I didn't feel anything, so I took more. Yes, the rookie edible mistake that we all know, also known as the moment you meet your ceiling fan on spiritual terms. It usually goes like this. You take the edible, you wait 20 minutes, nothing, you take more. And then somewhere around the 75-minute mark, you start understanding colors emotionally. The problem here is timing. Cannabis edibles do not work like alcohol or even smoking weed. Inhalation has a rapid onset, usually within 1 to 5 minutes, peaking around 15. Edibles, they're a slow train, 45 to 90 minutes to onset, with a duration of 6 to 8 hours, depending on your metabolism and your liver function. So when you stack doses prematurely, you're not being brave, you're being deeply committed to learning a hard lesson the experimental way. Inhaling THC and eating it are not the same. One's a short story, the other's a Russian novel. Edibles are like X's, slow to arrive, hard to predict, and linger longer than you planned. The science, same plant, different molecules. Here's where cannabis gets fascinating. When you inhale THC, it enters your bloodstream as delta-9 THC, the classic psychoactive compound. It hits fast and metabolizes quickly. But when you eat THC, it's processed by the liver first. There it's transformed to 11-hydroxy-THC, a different compound entirely. And guess what? 11-hydroxy-THC is 4 to 7 times more potent at crossing the blood-brain barrier. That's why edibles hit harder, longer, and often unpredictably. A study from Therapeutic Drug Monitoring showed that 11-hydroxy-THC reaches peak plasma levels at 1.5 to 3 hours after you eat it, and remains psychoactive much longer than smoked THC. And yes, it's the same plant, but by the time your liver's done with it, it's an entirely different ride. The method defines the moment. When patients ask, how should I take it? I ask, what's the goal? Do you need quick relief for panic or headache? Inhalation, fast in, fast out. Do you want help staying asleep through the night? Oral, delayed onset and longer duration. Do you need mood regulation that won't impair your function? Sublingual tinctures, faster than edibles but gentler than smoking. Do you have joint pain or menstrual cramps? Topicals, no high, localized effect. The route of administration shapes your onset, duration, and your potency, and even the side effect profile. You wouldn't microwave a croissant, so why don't you use edibles when you need longer lasting effect? And you wouldn't want to use an edible if you need relief in 5 minutes. The method defines the moment. Use accordingly. You control the effect by controlling the format. Here's the key shift in mindset. You don't just take in cannabis, you design your cannabis experience. You get to choose how fast it kicks in, how long it lasts, how strong it feels, all by choosing the right format for the job. Do you need relief in a flash? Use a vaporizer. Do you need calm that lasts through a long plane ride? Use a capsule. Do you need to avoid psychoactivity altogether? Use a topical. This isn't random, it's a toolkit. And format isn't just a preference, it's a prescription strategy. Telling everyone to take a 5 milligram edible is like recommending the same bra size to every woman. Your liver enzyme activity can influence your dose, so yes, your liver is more interesting than your bud tender. Just take 5 milligrams and see how it feels. Your dose isn't a number, it's a process. This one drives me nuts. It's not just bad advice, it's incomplete. because 5 milligrams for one person might just be a whisper. For another, it's a marching band in your prefrontal cortex. Why? Because people don't metabolize cannabinoids the same way. In pharmacology, we talk about inter-individual variability. Cannabis has a lot of it. Some patients have high CB1 receptor density. There's lots of those CB1 receptors there. Others have faster CYP2C9 enzyme activity. They're burning through cannabinoids more quickly in the liver. Then add in tolerance, BMI, hormone levels, gut microbiome. 5 milligrams is not a standard experience for everybody. It's a suggestion, not a solution. So no, don't treat it like a thermostat. Treat it like a dimmer switch, one that's wired differently in every house. Your body is the variable. This is where things get clinical. You're not a static input. You are a biological system in flux. Here's where we know. The enzyme CYP450 system, especially the C29, 3A4, and C19, affect how you metabolize THC and CBD. The COMT gene influences how your brain clears dopamine, which is important if you're prone to anxiety. Estrogen upregulates CB1 receptors, meaning sensitivity can fluctuate across your menstrual cycle. This is partly why women often report stronger cannabis effects than men at the same dose. One study in Frontiers of Pharmacology in 2018 showed that women are twice as likely to experience adverse effects from cannabis compared to men, even when they're matched for weight and dose. And that's just genetics. Add stress, illnesses, other meds, hydration today, baseline fitness, and you've got quite the moving target. Your body is the variable, so we need to treat it like a conversation, not a command. We've all heard this phrase so much it started to sound like almost Dr. Seussian. Start low and go slow. But here's what gets missed. Start with intention. Don't just take a dose and cross your fingers. Ask, what effect am I aiming for? When do I want it to start? How long do I want it to last? How alert or alerted am I comfortable being? Then track it. What did you take? What was the route? How did it feel at 15 minutes? 2 hours the next day? If you treat cannabis like medication, it behaves like medication. If you treat it like an edible lottery ticket, good luck. Real-world patients who keep journals or use structured digital tools like EOCare's platform report higher satisfaction and fewer side effects. So yes, start low and go slow, but with a compass in your hand, not a blindfold. Your ideal dose isn't a number, it's a process. Every other area of medicine personalizes dosing. We don't give the same amount of insulin to every diabetic. We titrate antidepressants to the person. We adjust blood pressure meds for people who have high blood pressure. Cannabis is no different. Your ideal dose isn't what's printed on the bottle. It's what your body confirms over time. And finding it isn't just trial and error. It's structured adaptation. You try, you observe, you adjust. That's the process. And once you embrace that mindset, cannabis goes from confusing to calibrated, from intimidating to empowering, and from guesswork to precision. Smart use is safe use. It's just a plant. It's totally harmless. This one really gets the Whole Foods vibes. It's natural, so it must be safe. And here's the thing. Arsenic is natural. So is hemlock. So are scorpions. Being plant-based doesn't give cannabis a safety halo. Yes, compared to opiates and benzos and alcohol, cannabis has an excellent safety profile. It's virtually impossible to lethally overdose on THC, but that doesn't mean it's risk-free. You can overdose functionally. Think panic attacks, vomiting, dizziness, or impairment of your fine motor functions. And for some populations, the risks aren't just theoretical. For example, cannabis can increase heart rate by 20 to 50% in the first hour after you use it, something to consider for cardiac patients. So yes, it's a plant, but that plant engages in a neuroimmune system that regulates mood and memory, inflammation, and your metabolism. That's not harmless, that's pretty powerful. And power needs structure. Most side effects are dose, setting, and format related. Let's talk about what actually goes wrong and why. Most cannabis side effects aren't because the plant is inherently dangerous. They're because it was used in the wrong dose, the wrong format, or the wrong setting. Common short-term side effects for most people include dry mouth, short-term memory fuzz, increased heart rate, drowsiness, and sometimes panic or anxiety, especially in people who are THC sensitive. Rarely, you can see things like cannabis hyperemesis syndrome. This is cyclical vomiting in chronic high-dose users, particularly with concentrates. And cannabis has been associated with 3 to 5 times increased risk of motor vehicle crashes when it's used within 2 hours of driving. But here's the good news. Most of these symptoms are reversible and avoidable. Lower your dose, switch to a different ratio, use a different route. Cannabis risk isn't like opioid risk. It's not toxicity, it's tunability. And tuning is where medicine lives. Yes, cannabis is safer than most meds, but so is peanut butter until you're allergic to peanut butter or you smear it on the wrong thing. Cannabis doesn't come with a black box warning, but it probably should come with a pamphlet titled, "So you ate too much." Some bodies need different rules too. For some patients, cannabis carries special considerations, not because of stigma, but because of physiology. Adolescents, their endocannabinoid systems are still developing. Unguided THC exposure in teens has been linked to changes in white matter brain density and increased risk for early onset psychiatric disorders. Pregnant or breastfeeding people, we lack really conclusive safety data. THC crosses the placenta, we know that, and until it's proven safe, it deserves caution and should be managed by the experts. Patients with psychotic disorders, high THC cannabis can worsen symptoms in those with schizophrenia or bipolar disorder. And patients on medications, cannabis interacts with the CYP450 enzymes in the liver, which means it can affect how you metabolize sedatives, anticoagulants, even SSRIs. None of this means these patients can't use cannabis. It means they need customized care, not generic advice. Because some bodies need different rules, and good clinicians adjust the playbook. Smart use is safe use. Here's the bottom line. When cannabis is used with education, planning, and feedback, it's among the safest therapeutic tools we have. The National Academies of Sciences concluded in 2017 that cannabis is effective for chronic pain, chemotherapy-induced nausea, and MS spasticity, and has low abuse potential relative to other drugs. Risk enters the picture when cannabis is used casually, chaotically, or without regard to context. Smart use meaning know your body, know your meds, know your tools. Cannabis doesn't need to be feared, it needs to be respected. And when it is, safety follows naturally. This isn't a confession, it's a conversation. My doctor doesn't need to know that I use cannabis. This is one of the most dangerous assumptions I think patients make, not because cannabis itself is dangerous, but because incomplete information is. People think it's from the dispensary, it's not a prescription, so my doctor doesn't really need to know. But cannabis can affect sedation, it can affect anesthesia, blood clotting, medication metabolism, and even hormonal regulation. THC and CBD both impact cytochrome P450 enzymes. which regulate how your liver processes many drugs, including warfarin, benzodiazepines, and antidepressants. If you're going under anesthesia, cannabis can alter how much sedation you need and how long it takes to recover. One study found that regular cannabis users might require 14 to 220% more propofol to achieve the same sedation during their surgeries. So this isn't about judgment, it's about safety. If your doctor doesn't know that you're using cannabis, they can't protect you. And if cannabis doesn't come up in clinical office visits enough, doctors will continue to avoid learning about it. They don't hear about it, they assume incorrectly that it's not so common, that it's actually overtaken alcohol in daily use in the US. Doctors don't have to love cannabis. They just have to know it's in the room, like a dog at a dinner party. Open communication reduces your risk. Patients who discuss cannabis use with their providers are more likely to dose responsibly and report adverse effects early. Your doctor might not be trained in cannabis, but they're still your point of care. It's true, most doctors never learned about the endocannabinoid system in school. In fact, fewer than 10% of US medical schools include any formal cannabis education at all. Over 90% of clinicians surveyed in a 2021 JAMA Network Open study reported little or no formal cannabis training whatsoever. But they do understand drug interactions, risk mitigation, your comorbidities, and your medication list. They're part of your care team, whether they're cannabis literate or not. You don't need them to approve your cannabis use. You need them to understand it. Because even a skeptical doctor who knows your history can help you avoid problems. And who knows, your openness might spark their learning. Medicine only moves forward when patients and providers are honest with each other. And medical schools aren't calling doctors back to school to learn more about it. Doctors are only going to learn if they feel pressured to be knowledgeable about it. Cannabis can interact with warfarin, clopidogrel, benzodiazepines, SSRIs, via these liver enzymes that inhibit processing. The conversation isn't a confession, it's a collaboration. So how do you actually bring it up? Try this. I'm using cannabis. I'd like to make sure it's safe alongside my other meds. Can we talk about it? That one sentence reframes the whole conversation. You're not asking permission, you're asking for support. If your doctor is dismissive or unhelpful, that's a reflection of their limitations, not yours. And if they say, I don't know much about cannabis, that's your opening to say, here's a resource. Here's the platform I use. Let's learn about this together. Collaboration starts with curiosity. And the best doctors, the ones you want in your corner, will thank you for starting that conversation. Cannabis care is a journey, but you don't have to travel alone. The most successful cannabis experiences are rarely solo projects. They're built with guidance, feedback, support. Think of your cannabis care like a map. You need a starting point, what's bothering you? A destination, what would relief look like for you? And a route, what formats, doses, and timing will get you there? You can build that map through reflection, through conversations with clinicians, through platforms that help you track and adjust. And you don't need to have it all figured out. You just need to be willing to learn your own terrain. Because cannabis care isn't about picking the strongest product. It's about building a system that works for your life. And with the right guidance, you're never walking that path alone. So what did we learn? We learned that cannabis isn't new. We just forgot it was medicine. It's been healing humans longer than we've had stethoscopes or even soap. It's not one plant. It's a pharmacist's toolkit. Over 140 compounds and dozens of terpenes, and none of them care what the strain is called. The delivery method isn't just logistics, it's strategy. You wouldn't send a smoke signal to make a phone call. Choose your route like it matters, because it does. The right dose is a moving target. Focus on your metabolism, your mood, your moment. Dosing is a dance, not a dartboard. Safe cannabis is intentional cannabis use. It's not dangerous, but it's not harmless either. Risk shrinks dramatically when curiosity replaces your chaos. Your doctor doesn't need to love weed. They just need to know that you use it. Open the door to that conversation. A good care team is built on information, not approval. So at this point in my talk, I had some questions, and I guess we'll skip that for this recording. But for people that are interested or have gotten this far, please reach out to my team at Seed Clinic. They're happy to offer either complimentary access to my newsletter, the Doctor Approved Cannabis newsletter, to anyone who drops us a quick email. It's a thoughtful, evidence-based newsletter, sometimes a little funny, depending on my caffeine level. I also teach online. Free videos, podcasts, social posts, the occasional meme that somehow makes it past my better judgment. So if you still want to stay in the loop or just want to learn more about cannabis at your own pace, I've made it easy to find me. I can figure out where these are. Other way, there we go. And with that, we'll call it a recording. Thanks everybody for watching. Let me know if I can help with anything.